Hi, and welcome back. My name's John. As many of you already know, I'm a type 1 diabetes patient for 45 plus years, and I'm also an emergency medicine physician in New Hampshire. Prior to moving to New Hampshire, I ran a diabetes center and urgent care office in New York. I treated diabetes patients, both type 1 and type 2, and some in between, for over 15 years. I created this channel to help raise diabetes awareness, to help share stories, to help have some fun and entertainment, and to let folks know that you're not the only one. Let parents know that we appreciate your support, and this is how I did it growing up. Hopefully, by sharing stories and ideas, we get some hints, we get some better thoughts, we have some fun, some entertainment, a few chuckles, and we're able to get something out of it. Please, especially the next few lectures in the series, do not look for medical advice here. I'm going to talk a lot about medical things, but I'm not here to advise you. I'm here to entertain you. If you hear something or see something you might like to try, just talk to your provider. So, the first group of the series was about my life, and honestly, I'm getting bored. My life isn't that exciting. I have made diabetes a lifestyle for me, and we certainly will have more videos talking about the lifestyle of diabetes. But as you heard, I got through high school and grade school. I got through camp. I got through college. Had a great time, learned a lot, had a lot of ups and downs. But all in all, like I've always said, diabetes is a lifestyle, not a disease. And you're the driver. It's sitting in the back seat. It needs to be respected and acknowledged, but don't let it run your life. So today I thought we'd do something a little bit different. Now we'd look into a little bit of the differences between type 1 diabetes and the other much more popular, I'm not sure if that's the right term, but much more common form is type 2 diabetes. Then after that, I'd like to split into different therapies. I don't have enough time to do both the therapies for type 1 and type 2 in the same series, so we'll continue this next week. So type 1 diabetes, let's start with that. It's my personal favorite. It's very simple. It's a black and white disease. You don't make insulin. Done. So the treatment obviously is replace what you don't make. So why don't you make insulin, and what is insulin? So insulin is a hormone. It's made in the beta cells of the pancreas, and the pancreas itself is a small endocrine gland that sits behind the stomach. What the pancreas does, because of the blood flow around it and through it, and its connections with both the liver and the stomach, or small intestine, is it monitors the blood glucose better than ever. You can check your blood sugar 20 times a day. Your pancreas is doing it every millisecond. And the beta cells, in response to blood sugar, will release insulin. So as the sugar starts to climb or as some food hits the stomach, the beta cells know what's going to happen and they will release insulin to cover it, such that the blood glucose levels, what we test on our fingers, stays within a tight range. Now, can it go up? Sure. Infection, major stress to the body can cause it to go up, but for the most part, it stays in a nice tight range. Can it go down? Absolutely. You have people that experience hypoglycemia. You have some of these marathon runners that really have to pay very careful attention to how they feel because they don't have a lot of stored sugar on them and they're depleting their resources when they run. So both of the highs and the lows can happen to folks without diabetes, but for those of us with type 1, we live and deal with it every day. So that's what the pancreas is. What insulin is a much more difficult answer. And I think the last lecture series I went to about insulin was about 8 or 10 hours long. So insulin is a hormone. And I don't believe we have a complete understanding of all of what the insulin does. The most important thing that we know is it regulates blood glucose levels. So patients often ask me about this, and it is a difficult concept, so bear with me. Think of your body as a series of rooms, maybe a huge long hallway with various rooms. Each room is representing a different compartment of your body. So we've got the digestive system, we've got the blood system, we got the space in between the blood and the cells, and then we have the cells. So our goal in life is to support our growth and development so that we can be functional members of society and spread our genes and all the Charles Darwin stuff. We need keys to get through those doors, and insulin is a lot of the key. So let's take a patient without diabetes. they eat a slice of pie. That pie goes into room 1. The pancreas, who is surrounding room 1, is paying attention and sees the blood glucose starting to go up and knows it's going to go up more. The digestive system, room 1, has a job of taking that pie, taking all the good stuff out of it, specifically the glucose, which is the energy in the pie, so that we can use it. So that pie is going to exit door number 1 and leave the body. We take all the good stuff out first. So all the glucose goes into door number 2. Not going to worry about the other nutrients. Door number 2 are the blood vessels. This is the blood system, the circulatory system, being pumped around by the heart. So now door number 2 has all of this glucose. The pancreas has responded appropriately, and the beta cells of the pancreas have produced insulin to control that glucose level, to make sure it doesn't go too high, and to allow those glucose molecules to get out of door number 2 and into door number 3. And that is the cells of the body. So some cells don't need insulin. They have an open door policy, and that's the brain cells. For obvious reasons, we want our brain to be functioning at all times. Muscle cells also can really loosen up the lock and sometimes let glucose in with activity. So as you increase your activity, you go for a jog, you increase the muscular demand for energy, and the insulin demand or insulin portion of it is reduced and much easier to get the glucose into the cells. So that makes sense evolutionary speaking, because I'm running from the bear. We don't need to worry about getting that key to open that door to get the energy into the cell. We need to run. We need to run fast. So that's why that bypass occurs. So that's how the blood glucose now back to door number 2, blood vessels, the glucose is back down and stays where it needs to be. So the pancreas and the beta cells will do this by leaving a little bit of insulin around all the time. We call that the basal insulin. And giving extra whenever you eat, or you get sick, you have a stressful event, you have a traumatic incident, whenever they need to control spikes in blood glucose. So don't be fooled that glucose only spikes when you eat. There's a lot of other things that can cause it. So that's the basic room ideology of handling glucose levels for a patient without diabetes. So now for us with type 1, we're not going to eat the pie. We're going to have a sandwich. Okay? The lettuce, the meat, who cares? The mayonnaise, the fat from that, who cares? It's really the glucose from the bread that's going to cause us to have a high blood sugar level. So that the sandwich comes into door number 1. Sandwich is digested. All the good stuff is taken out. Part of that being the glucose for energy. That goes into door number 2, which is the blood system, the blood vessels, the circulatory system. Now the blood sugar is elevated, but there's no insulin. So now all of the other cells, all the other doors can't get to the sugar, except the brain. And if we're running, we may have some success. So because that blood glucose is higher, think of it as a stream that has a lot more rocks in it now. 2 friends of ours, our kidneys, don't like this. They like balance and precision. So they see all of this extra glucose, and through special doors at the kidney level, they move that glucose out. Basic rule of thumb for the body. If you're going to move a solid out, like glucose or potassium or sodium, any solid particle like that, it needs something to go with it. Water. So now my blood sugar is high because I have no insulin. The kidneys are taking out all of that glucose and putting it into the filtration system to go into the bladder, which requires water. So now the kidneys say, oh, the water levels in the body are a little bit low. Turn on the switch and make him thirsty. So now I'm drinking more. I'm drinking more water to cover the amount of glucose going into the bladder so that it can be excreted or urinated out. So, what's going on here? There's a lot of glucose in the blood. I'm drinking more to help get it out of the body, and as a result of that, I'm urinating more. 2 of the most common symptoms of diabetes is Increased thirst, increased urination. And that is why. Let's flash back to pre-insulin. So prior to 1921, children were diagnosed with type 1 diabetes. It was about a 6-month lifespan after that. They weren't told, but their parents are told that there really is no treatment and your child may make it 6 months with aggressive therapy. So what is aggressive therapy? This is a black and white disease. We don't have insulin yet. So what is aggressive therapy? Food was measured. They paid more attention to starches, but essentially carbohydrates. They didn't have the knowledge of food that we do now. At the same time, they didn't have the types of food we do now, which is a good thing. But the children would be given a certain amount of food, so maybe some turkey and maybe some mashed potatoes. And for every ounce of those mashed potatoes they ate, they had to be active. They had to walk around. They had to burn off the calories. What the concept was back then is that, okay, they're using that sugar, they're burning it, so it's not going to bother them. Keep in mind, we have no blood sugar testing. We barely have urine testing. Most of this is a send away. So what really is happening is because of the activity, the muscles are a little bit more receptive to insulin. It's not a slam dunk open door, but it's better. So they can reduce some of their glucose levels. The problem that befalls them is they can never get it where it needs to be. Their cells are starving, and eventually their cells say, hey, you know what? Plan A is how we make energy. Plan A depends on glucose. Plan A depends on insulin to let us have the glucose. This isn't working. Let's go to Plan B. So Plan B is anaerobic metabolism. So now we'll start producing energy in a different method. Some of the side effects of that is acid production. Well, the cells don't want that acid in their house, so they push it out into door number 2. So now the acidity of the blood rises, and these patients become acidotic. Over time, because door number 2 often involves digesting yourself, these children become rail thin. They are starving, both mentally and physiologically. Their body is going through all kinds of processes to compensate for the high glucose levels and the acid. They're told they have to walk, but they're wasting away. They literally don't have the muscle power to really walk. And this progresses to coma and death. So it's pretty intense on how they try to treat it, but without that main ingredient of insulin, it's a no-win scenario. So that stresses to you the importance of insulin. What I mentioned earlier, and I want to come back to, is we don't know all of what insulin does. Dr. Ben Bikman, who's an excellent author and excellent lecturer, does a lot of work with insulin resistance. And even he will tell you he doesn't believe the scientific community has figured out all the ins and outs of insulin. He will tell you how insulin resistance is tied not only to type 2 diabetes, it's tied to obesity, it's tied to cardiovascular disease, it's tied to stroke, it's tied to some cancers, it's likely tied to depression and poor sleep, where insulin resistance is a major, major issue. And I hope, not to get off topic, but I hope we do change our viewpoint on not so much type 1, but type 2 diabetes to understand this and treat it more appropriately. Back to type 1. So our goal of treatment is to maintain that blood glucose level where it should be. When the glucose level gets too high, then the kidneys work hard to get rid of the glucose. They need a lot of water to do that. We drink more, we pee more. You and I know exactly what's going on. You can tell just by the number of times you've used the bathroom or had a glass of water, or honestly, for me, even how that glass of water tastes. I always tell my friends without diabetes, you've never known thirst until you've had a high glucose and don't have easy access to water for a few hours. There is no greater taste in the world than that glass of water, followed by the next 5 glasses of water. So this is what's going on at a very basic physiological level. How do you and I monitor our treatments? Well, we need to know what's that blood glucose level. So I think my first or second lecture talked about the blood meters back in the day. They were large. They sat about yay big. Took about 2 minutes. You had to wash off your strip. You had to blot it. You had to air dry it. Put it in the machine. And you got a number. Was it accurate? Who knows? Before that, we relied more on using urine strips to look for glucose in the urine. But if you step back a few minutes to how I described insulin and blood sugar for patients with type 1 diabetes, that glucose in the urine isn't immediate. That's more stored. So it's not a here and now scenario. Testing your blood sugar is fairly accurate. And naturally, when the hospital draws your blood, because they're getting it from a vein rather than a capillary, they get a more accurate assessment. So we measure the blood glucoses at home. We have better meters now that take about 5 seconds, take a tiny amount of blood. They're small, they're easy to carry with you. They make life real simple for us. We also have the continuous glucose monitoring systems. I'm wearing mine here. Mine is the Medtronic Guardian. What these do is they communicate either to your phone or a separate device or to the insulin pump itself your blood, your tissue glucose level every 5 minutes. So this gets back to our door scenario. We have the door, room number one with the digestive system, room number two being the circulatory system. Then there's that space in between the other doors, the fluid in between the cells. This is where the sensor sits. So it's not exact, it's not precise, and honestly, I don't care about my number right now. What I care about is my number over the last 45 minutes to an hour and what direction it's going. So the secret to using your continuous glucose monitoring system is looking at the trend. That's the magic of it, because you can see your direction. You can see a low coming before it happens. And a lot of the software in these systems will detect it and alert you or even alert other people. They're wonderful devices. The big ones are Medtronic and Dexcom, and they do a phenomenal job. And I know there's a lot of other smaller companies out there working on some, so I wish them all the best of luck. So, continuous glucose monitoring system, blood sugar testing, back in the old days, urine testing, all ways to give us an idea of our blood glucose levels. What does our provider use? What does the hospital use? They'll use one of two things, more than likely just the one. Most common is the hemoglobin A1C. So the hemoglobin A1C, quite simply put, is they take a blood cell, and blood cells have a tendency to connect with glucose particles in the blood. So they count them. So they count them all, and they come up with an average number. The blood cell lives for about 90 days. That's why we do our hemoglobin A1C every 90 days. And that will give a number that we can mathematically correct to give an average blood glucose. So we'd all like to be in the 6 range. People without diabetes tend to hang out under 6. I'm not a huge fan of the A1C, and I'll tell you why. It's an average. I could have an A1C of 6 with a lot of blood sugars in the 40s and a lot of blood sugars in the 300s, neither of which is good for me. Those wide swings in blood glucose levels lead to all kinds of problems, and obviously blood glucose levels of 40 is a safety issue. So the beauty of the continuous monitoring system is I, as a provider, can say, hey, your glucose is, your A1C is 6.5. That's really good. Oh, wait a minute. The tracings on your CGM, your continuous glucose monitoring system, show you're all over the place. That's not good. I'm not doing my job. You're not doing your job. Let's figure this out. Or ideally, your glucose is 6 and there's essentially no lows and no highs. That's phenomenal. You're staying within a target range. We like the time and target better than the A1C. So I'd like my time and target to be 100%. Obviously, it rarely is, but it's the concept of trends of blood glucose levels and how that works with an average, which is the A1C. Fructosamine, I may have mentioned, this is essentially a 2-week A1C. I used to use them occasionally with more difficult patients. It can be a good guidance, but not nearly as good as a CGM. And I think the A1C is just easier to get. So we know what's going on between type 1 or with type 1 patients. We know how to treat it. Don't make insulin, we give you insulin. We know how to monitor it. Our goals, again, I will stay away from setting a goal A1C or blood glucose level for everyone in the world. I will set it for individuals. In other words, my 25-year-old construction worker, he and I have an idea where we want his glucose levels to be, where we're comfortable. He may be climbing ladders. He may be out on scaffolding. He may be using heavy machinery. He could be in high-risk situations where we certainly don't want low sugars. So he might aim for a little bit higher during that time. My little old lady, who's been dealing with type 1 diabetes for years and lives alone, is very independent. She's certainly at risk for falls and breaking a hip or other issues, so I don't aim quite as low, because with our current therapies, most of our current therapies, when we aim for a lower average glucose level, we risk having more lows. Granted, the CGM has fixed that tremendously for us, and we have far less low blood sugars because of it, but that is a risk we take. So I believe in setting individual goals. I recommend you set your goal, talk to your provider about it, know where you're comfortable, where you want to be. Because I'll tell you this, and those of you that have worn the sensor for any length of time may have a similar experience, and please leave a comment. I would wake up in the morning with a blood glucose of 40. I'd get up, I'd get dressed, I'd go downstairs, totally fine. Get something to eat, be fine. Knew I was low, but was completely functional. Flash forward another week, I wake up at 70 and I can barely walk a straight line. And no, it's not because I imbibed in anything bad. I'm just all over the place. I'm confused, I'm feeling off, I feel horrible. I'm only 70, who cares? But when you look at the sensor, back to night 1 when I woke up at 40, it was a nice, slow, gradual decline. Night 2 at 70, dropped like a rock. The human body does not like rapid change. You remember your, I don't know what grade they do biology in anymore, but remember your biology days in grade school and high school, talked about equilibrium. The body loves that word. It's balance. We see the same thing with fevers. When a pediatric infant or young toddler has a high fever, I often see people in the ER for it because they're scared about a febrile seizure. And again, it's not so much the height of the fever, but how quickly it changes. The body does not like that rapid change. So back to our continuous glucose monitoring systems, give us a wealth of information. So how are we going to use that? We'll flash back 45 years. I was on insulin. I was on 2 shots a day. Is that right? Am I lying to you? Yes. This is the old days. This is back with pork and beef insulin. The insulin manufacturing process and the DNA and RNA uses have gotten tremendously better. But essentially, I would take a certain amount of regular insulin, which is more of the fast acting, and NPH, which was a medium acting. So NPH would last for about 12 hours, but it would spike. In other words, the levels in the blood would rise at the midpoint. Very variable, never did what it was supposed to do every single day, and required you to be extremely rigid to have lunch, because if you miss lunch, you're going to have a low sugar. So essentially what I was doing is I was taking that short-acting insulin to cover breakfast, the medium-acting insulin to cover lunch, and then again at dinner time, we repeat the process. You can see how this can cause issues overnight, which is why that dinner dose needs to be adjusted appropriately. But the goal is I wake up with a fasting blood glucose, in other words, a period of time without eating, in range. This has all progressed to the more rapid acting insulins, the far more pure, better made Humalog and Novolog are the big ones. I think there's some generics out there now as well. And the longer acting insulins, Levemir, Lantus, and Tresiba are those to reduce the number of injections, give more stability, give more regularity, and get rid of that variability. So we'll go backwards. Tresiba is probably the newest, longest acting insulin that I'm aware of. And there may be some others. Like I said, I've been out of that game for a little bit. Tresiba lasts for about 36 hours. And once it's in the system, you get a very, very flat profile. So this, if you remember back to how the pancreas works, what we're trying to do is replace the background insulin, the basal insulin levels. We adjust that dose based on fasting glucose levels. So I used to use I think it was a 303 rule. You check your morning glucose for 3 days. If you're in range, great. You don't change it. If you're too low, it was a 202 rule. If you're too low, you went down by 2 units. If you were perfect, you went 0. You didn't change it at all. If you were too high, you went up by 2 units. And you did that every 3 days until you got where you wanted to be. Your other long-acting insulin is Levemir and Lantus. Lantus has been around forever and a day. A little bit more variability with these, and they don't last quite as long. They're only about 24 hours, but they can be given once a day, and they're fairly simple. The shorter acting insulins, and now the rapid, or extra short, I'm not sure what they're calling it, but the Humalog and Novolog are dosed before meals. So back to our pancreas, we have that background insulin that we've created with the Tresiba. Now we're giving the Novolog or the Humalog before a meal or before eating so that we cover the rise in blood glucose. A couple of issues here. We have to balance the absorption of the glucose, which is impacted by the type of food and amount of fat in that food, and the absorption of the insulin, which is impacted by the type of insulin, where you inject it, recent or current activities. So, for example, you go for a run and you inject it in your muscle of the leg, inject into the subcutaneous tissue over the muscle of your legs, it's going to work a lot faster. So, there's a lot of variables there that we have to try to balance to maintain that blood glucose level. How do you dose it? Typically, it's dosed based on what is my blood sugar right now, where do I want it to be. I always call that the correction factor or sensitivity factor. And what am I eating? What am I about to do to my blood sugar? So somebody who walks into lunch with a blood glucose of 100, maybe they were working out in the morning and they're only going to have a salad with some pieces of chicken on it. If there's no carbs there, they essentially don't need to dose. So that's where we've improved things. If you went back to my youth, no matter what you ate, you were dosing. So you learn that you couldn't just have a salad. You couldn't just have a piece of meat. You had to have some carbs. Otherwise, you would bottom out. So that's the main groups of insulin. There's also faster than fast. I forget what they're calling them now. Apidra is my personal choice that I use. Humalog also, or Eli Lilly makes another one. These are very, very rapid acting insulins. So they start action much quicker and their impact is great. I use that in my insulin pump and it works phenomenally. There's also not so much created for type 1s, but the U500 insulin, which is a higher concentration, and a U300, but we don't need to get into that stuff since the type 1 folks use the purest and the best that we can get, and we use as little as we can. So that's how we have it. I grew up in the days of the bottles and syringe, so you squirted the air in, you drew out the insulin, you could mix you could mix the regular and the NPH without any issues. So that was one shot, which was a huge factor for kids. Nowadays, they're separate, but nobody uses those anymore. So we have the insulin pens now, which work both audibly and tactfully and visually to give you the dose. You can feel the click, you can hear the click, you can see the number so that you get the appropriate amount. Some companies, I believe Novolog makes a junior pen that does half unit doses for us that are really sensitive to the insulin. These are literally, I wish I had one here with me, but it's a little bit wider and taller than this pen. So it fits in the pocket really easily. You can store it in a little cooler. You can keep it with you at all times. And this gives you the flexibility to live your life more like quote unquote normal people. So, you plan on going out at noon back in the day. Well, you had your MPH on board, so you had no choice. But your friends can't make it till 2. So, now you're standing out. Now you're looking different. Now you're feeling annoyed with life, or you're risking a low blood sugar. Nowadays, you're carrying your Humalog Quick Pen or your Novolog Flex Pen or your Fiasp Flex Pen. That's the rapid one. They decide to change the time of lunch. That's fine. With the rapid acting ones, the Fiasp, you can take it after the meal, so you know exactly what you ate. You actually avoid the issue of I meant to eat this many carbs and I didn't quite feel like it. Maybe I have a stomach bug, and now I have a low sugar. So these advances in the quality and the types of insulins produced have been phenomenal for us. The other method of getting insulin, again, my personal favorite, is the insulin pump. So there's the Omnipod pump, there's the Tandem pump, and there's the Medtronic pump. I've worn all three. I started my insulin pump during my first year of residency in Syracuse, New York. Fell in love with it, and I've been using it regularly ever since. I think I maybe took a pump vacation of less than a week. Sorry. So simplifies everything. The pump, back in the day when I started, I think this was about 2001, the pump would use an insulin correction factor, a time factor, and a carbohydrate ratio to determine your dose when you bolused. You would set your basal rates based on time of day. So you could, when you take your Levemir or your Lantus, you're getting one injection for that whole day. With the pump, you could adjust that rate every half hour. So you can really customize it to your day. You could customize it to your work week and your weekend, and with a few button pushes, switch between what we call basal or background insulin patterns. Nowadays, the pump works much closer with the continuous glucose monitoring system. So this information is being sent not only to my phone, but to the pump, who under the 780G system of Medtronic will do micro boluses based on data from that. So you truly look at your time in range, and based on your insulin sensitivity and your active insulin time, meaning how long is it in you working, the pump makes adjustments to what you're getting. You can change your goals. If you're going to be active, you may want your goal to be a little higher because you know your activity is going to lower you. But all in all, this is as close as we've ever been to making a closed loop. I still need to talk to my pump about meals, especially if there's any significant carbohydrates in the meals. And once in a while, excuse me, I'll get an alarm to check the blood glucose. But for the most part, I don't test with my finger anymore. I don't dose except for specific meals. And again, the pump is making a recommendation, and 9 out of 10 times I agree. And I don't have to worry about the background insulin at all because it's all completed for me. So the pump is an extremely complicated device, and I would love to get into it more. I didn't spend as much time on the Tandem pump or the Omnipod. I did wear the Omnipod a couple of different times. Very similar technology. I prefer Medtronic's algorithms and their technology. They also have excellent customer service, but I'm sure every company does. But regardless of which pump you choose, or in today's world, our insurance tells us we can have, I highly recommend you do look at that, because it is a much more human way of giving what you and I are missing. So we've looked at the basics of type 1, the basics of insulin, and again, extreme basics of insulin. That's an incredible amount of wealth of knowledge and really incredible stuff. We'll talk about diet and exercise in a future lecture. We're going to talk about type 2, I think probably next week. They have a lot of different options, although most of them most of what we talked about today will be included with next week. We talked about how we monitor our glucose and the beauty of the insulin pump. I encourage you to leave me some comments, leave me your thoughts and ideas. I apologize if this one got long. There's a lot of information and it's a lot of fun, especially for me. If you have any thoughts, questions, please leave a comment. I'd love to respond to you, love to have a discussion. Please let us know if you like us, subscribe to us. We appreciate any support and feedback we can get. Share this with loved ones, share this with friends or people that have questions about diabetes. I hope I simplified it for you. If you feel there's a topic or a portion that I could have done better, let me know, and I'll be happy to post another bonus video or something to help out. So thanks for everything. I hope you guys enjoy this. I hope it brought some light to a very dark and confusing world. And of course, as always, stay healthy.